The many phases of secondary angle closure glaucoma, a practical approach to unveil. Secondary angle closure glaucomas can be challenging even to seasoned glaucoma experts. More often, multiple mechanisms are involved in angle closure, which can be picked up by a detailed history, gonioscopy, ASOCT, and UBM imaging. We aim to simplify the secondary angle closure by this classification to understand better. We will present a series of case scenarios and describe how we diagnosed and treated angle closure in them. Absolute pupillary block may result from formation of posterior synechiae. This patient had developed iris bombay post-cataract surgery due to persistent inflammation. Laser iridotomy was done and anterior chamber deepened immediately. However, laser PI may not be helpful in eyes with 360 degrees posterior synechiae with a flat AC as in chronic uveitis. This is a 2-week post-op image of a patient who had iris claw IOL implantation. Laser PI was done the same day. Note the immediate deepening of AC and a patent PI. Hence, it is better to do surgical PI in these patients. This patient was referred to rule out malignant glaucoma. UBM showed an FM bridging the pupillary margin. Note the position of IOL reflex. Patient was treated with intense steroids and laser PI. AC deepened post laser PI. In malignant glaucoma, one can expect forward movement of the entire lens iris diaphragm with uniformly shallow AC. This patient developed shallow AC on POD1 after iris claw IOL with a patent surgical PI, a classic presentation of malignant glaucoma. Patient was started on atropine eye drops along with post-op steroids. 3 days later, AC deepened. Undiagnosed silicone oil induced angle closure can lead to corneal decompensation as shown in these images. This image shows pupillary block by silicone oil. Post PI, silicone oil bubble retracted and AC deepened. Next is a patient who had both silicone oil induced pupillary block and silicone oil overfill in the AC. Overfill can be diagnosed by a shiny reflex over the iris as in this patient. We did a partial SOR with AC reformation and an inferior surgical PI. Inferior surgical iridectomy is helpful to prevent these problems, especially when silicone oil is done in aphex and pseudophax. Disorders involving the position and size of the lens can also result in pupillary block and secondary angle closure glaucoma. This is a case of phacomorphic glaucoma. ASOCT shows fluid-filled cleft in cataractous lens indicating a high intralenticular pressure. IOL master also shows a very shallow AC depth and lens thickness. This is the biometry of a nanophthalmic patient who underwent cataract surgery with IOL implantation. As seen here, the anterior chamber depth is shallow even after cataract surgery. UBM also points the same with a persistent angle closure. The weak and abnormally elongated zonules in microspherophakia cause an anterior movement of the lens leading to recurrent angle closure attacks. Laser PI helps in preventing the attacks. This young male with high myopia presented with acute angle closure in both eyes. UBM shows a small spirophakic lens and elongated zonules. UBM is helpful to identify the cause of IOP spikes post-cataract surgery. This image depicts the IOL position where the haptics are seen in the sulcus causing secondary angle closure with pus. The slit lamp examination shows a classic transillumination defect along with the contour of the IOL, especially at the IOL haptics. Eyes syndromes are one of the notorious causes for refractory angle closure glaucomas. The abnormal endothelial cells in these eyes eventually form a membrane, the contraction of which leads to high pass. NVG is characterized by a fibrovascular membrane that gradually causes angle closure. These images represent extreme forms of ectropion UVA. These glaucomas are usually refractory, requiring multiple surgical interventions for IOP control. This patient was referred to us 1 month after an uneventful cataract surgery for iris bulge. UBM revealed multiple small to medium-sized ciliary body cysts and an IOL in the bag. Laser PI can be done prophylactically in phakic patients with occludable angles due to ciliary body cysts. Drug-induced angle closures should be suspected in cases with bilateral acute angle closure. PI is not needed in such cases as angle closure here is because of suprachoroidal effusion. The offending drug has to be stopped. Soemmerring's ring is a complication encountered frequently after congenital cataract surgery due to proliferation of lens epithelial cells. This aphakic young male was referred to rule out iris bombay. UBM showed extensive Soemmerring's ring induced secondary angle closure with high pass more in the left eye. Laser PI has a limited role in these eyes as there is no pupillary block here. Surgical PI with Soemmerring's ring extraction can be done in refractory cases. This is POD1 picture of a patient who had severe positive pressure with pain on table and IOL implantation was deferred. Slit lamp examination showed a uniformly shallow AC with vitreous prolapse through the PCR. B scan showed a localized aborted suprachoroidal hemorrhage. To conclude, prompt identification and treatment is crucial for managing secondary angle closure glaucomas. Treatment can vary from a simple laser iridotomy to a complex glaucoma drainage device implantation. Thank you.